Number 10. Pulmonary embolism risk factors and prevention groups of patients and actors. Pulmonary embolism arises from a complex interplay of factors that predispose to venous thromboembolism, VT, including deep vein thrombosis, DVT. Understanding these risk factors is crucial for identifying patients at high risk and implementing effective prevention strategies. Risk factors for pulmonary embolism: thrombopoietin inherited factor 5, latent prothrombin gene mutation, or acquired antiphospholipid syndrome disorders that increase clotting propensity, immobility or reduced mobility, prolonged bed rest, long-distance travel, paralysis. Surgery and trauma, especially orthopedic surgery, hip or knee replacement, abdominal or pelvic surgery, and major trauma can serve certain malignancies. Pancreatic, lung, brain, ovarian, premature pancreas VT risk. Previous VT through DVT or PE significantly raises the risk of recurrences. And age risk increases with age, particularly in individuals over 60 years. Estrogen containing medication or contraceptive hormone replacement therapy. And certain cancer treatments can elevate VT risk, and pregnancy and postpartum period increases risks due to hypercoagulability and venous stasis, venous compression with the graft with jitters, other medical conditions, heart failure, chronic respiratory diseases, and inflammatory bowel disease, nephrotic syndrome, and obesity, smoking, tobacco use, exacerbates other risk factors, particularly in combination with oral contraceptives. Prevention of pulmonary embolism in hospitalized patients, pharmacological prophylaxis, low molecular weight heparin, LMWH, unfractioned heparin UFAs, or fomdaprolins. Particularly for patients undergoing surgery or those to reduce mobility, direct or anticoagulant DOAC may be considered in specific patients' population, and mechanical prophylaxis, glittery decompression, stockings, disease, or intermittent pneumatic compression devices, especially when pharmacological prophylaxis is contraindicated in surgical patients holding mobilization. Encouraging movement as soon as possible post-surgery to reduce risk. Extended prophylaxis up to 4 weeks post-discharge for high-risk surgical patients, particularly after major orthopedic surgery. In cancer patients, LMWA is preferred for prophylaxis and patients with active cancer, particularly those receiving chemotherapy or reduced mobility. During pregnancy and postpartum risk assessment, individualized assessment to identify women at risk with increased risk for VTA, considering both pharmacological and mechanical prophylaxis options, and postpartum prophylaxis for women identifies at high risk, especially in the presence of additional transient risk factors in our population. Lifestyle modification, maintaining a healthy weight, regular physical activity, and smoking cessation, awareness and education, informing patients about the signs and symptoms of DVT, especially those risk factors, to ensure prompt medical evaluation. High points, individualized risk assessment essential for tailoring prophylaxis, considering the patient's risk factors, medical history, and current clinical situation. Pharmacological prophylaxis, the mainstay for at-risk hospitalized and surgical patients, with underage being commonly used mechanical methods, important adjunct, or alternatives when anticoagulation is contraindicated. Cancer and surgery high-risk categories require vigilant VT prevention strategies, and prevention of PE involves a multifaceted approach that includes risk factor modification, pharmacological prophylaxis, mechanical methods, and patient education to reduce the incidence and morbidity associated with these conditions. Okay, so let's sum up the number 10 pulmonary embolism risk factors that prevention groups of patients. That those pulmonary embolism arise from a complex interplay of factors that predispose to venous thromboembolism, including deep vein thrombosis. So risk factor for pulmonary embolism thrombophilia, inherited or acquired antiphospholipid syndrome, or inherited from factor 5 related prothrombin gene mutation and immobility or reduced mobility, and severe trauma, cancer, previous VTA, history of DVT or PA, and age, estrogen containing medication, pregnancy, postpartum period, other medical conditions, and smoking and prevention of pulmonary embolism, including in hospitalized patients, pharmacological prophylaxis like low molecular weight heparin, LNWH, and fractioned heparin UFAs or fondaparinux. For surgery, those reduce mobility and direct oral anticoagulants DOAC may be considered in specific patient population. And mechanical prophylaxis graduated recommendation stacking certain intermittent pneumatic compression devices in surgical patients only mobilization. Encouraging movement as soon as possible post-surgery to reduce PT risk and extended prophylaxis up to 4 weeks post-discharge for high-risk surgical patients and cancer patients. LWH group prefer for PT prophylaxis in patients with active cancer, particularly those receiving chemotherapy or reduced mobility, and include simple postpartum risk assessment postpartum prophylaxis, general population, lifestyle modification, awareness and education, high alcohol individual risk assessment, pharmacological prophylaxis, LMWH, being commonly used, mechanical methods, and cancer and surgery, prevention strategies.